I'm Christopher Mody. I'm Director of Clinical Affairs for Heidelberg Engineering. My role within the company is predominantly medical education and training.
Hello, I'm Richard Gale. I'm a consultant medical ophthalmologist practicing in York, UK. I manage patients with inflammatory eye disease and medical disorders of the retina.
The following video demonstrates the application of a systematic review of OCTA images in a series of patients presenting with various types of choroidal neovascularization. This case is of an elderly patient who is visually symptomatic, who presents with a region of subretinal fluid visible within the colour fundus image, a grey lesion and a small area of subretinal hemorrhage. The OCT-B scan shows an area of subretinal fluid, a shallow elevation of the retinal pigment epithelium and a region of subretinal hyperreflective material. The OCT thickness map shows an area of retinal elevation and thickening, which could be consistent with the changes that we observed in the OCT-B scan and the fundus image. We start our assessment of the OCT-A images by viewing the display tab and adjusting the B-scan image for magnification. We can now assess the quality of the segmentation. Moving the green line on the en-face OCT image allows us to identify where we are seeing areas of flow within the B-scan imaging and correlating that to the appearance on the en-face or transverse section OCTA image in the avascular zone or avascular complex. Moving to the OCT Angiography tab allows us to apply our systematic approach to evaluating the images. We start out by looking at the retinal segmentation. This identifies a vascular lesion. Using the full segmentation, identifies a second vascular lesion. Both of these show overlying retinal vessels, so we know that these are in a subretinal location. Superficial vascular complex is normal. Deep vascular complex again appears normal. The avascular complex shows a clearly defined vascular lesion. The choroicapillaris segmentation shows another vascular lesion and the choroid disorganization or disruption to the choroidal vasculature. Using the slider tool and sliding down from the ILM position through the retina, we see normal superficial vascular structures within the retina. We then identify our first vascular lesion. We then co-localize this position and zoom in on the B-scan image. We can see the segmentation slab is in a position that's anterior to the RPE, and therefore the flow that's being demonstrated in the transverse section OCTA image is being derived from a position anterior to the RPE, so we're looking at a type 2 lesion. Moving the segmentation slab deeper allows us to identify a second lesion, co-localizing that position again, and zooming in on the B-scan image shows a shallow elevation of the retinal pigment epithelium, and the flow is located in a position that's below the RPE, so we have a type 1 component. Adjusting the segmentation slab position to a position now anterior to the RPE, on the transverse section OCT image, we see regions of hyperreflectivity. When co-localizing this, we see on the B-scan images regions of subretinal fluid, indicating that we may have an exudative or active area of choroidal neovascularization.
These are very nice images of a type 1, type 2 mixed choroidal neovascularization. Often we find that the image quality is maybe not quite so good, and a danger may arise is if the clinical picture is suggestive of choroidal neovascular membrane but we can't prove it. Type 2 images are more easily seen, and in my opinion type 1 have been more difficult to identify. If the OCT angiogram does not confirm what we suspect, then we have to think of what the next step is. Either we can put together the clinical picture and the structural images and make a diagnosis, or if a diagnosis needs confirming, then conventional dye-based angiography may need to be used.
The following case is of a patient who has failed to respond to treatment for neovascular AMD. The fundus image shows a typical AMD appearance. The early fluorescein angiogram shows a small hyperfluorescent lesion with some areas of masking. The late phase image shows extensive leakage, cystic change, and again masking caused by hemorrhage. The ICG angiogram again shows a small hyperfluorescent lesion in the early part of the dye transit, which becomes more intensely cyanescent in the late stage of the angiogram. The OCT B scan shows elevation of the RPE with disorganization of the trilaminar structure, intraretinal cysts, evidence of exudate, and a region of hyperreflectivity immediately anterior to the RPE. The OCT thickness map again shows a region of retinal elevation and thickening. The OCT angiogram in the display tab. Firstly, we will increase the size of the B-scan image, assess the accuracy of the segmentation, move the B-scan location up and down, and correlate the position of flow on the on-fast OCT with the B-scan image. Moving then to the OCT Angiography tab. Initially looking at the retinal segmentation, we can see a small vascular lesion with overlying retinal vessels. Using the full segmentation confirms the same information. Superficial vascular complex looks normal. Deep vascular complex shows a small vascular lesion with anastomosing retinal vessels, which is then confirmed on the intermediate and deep capillary plexus. A small ring-like vascular lesion is then observed in the avascular complex. The choroid capillaris looks relatively normal, as does the choroid. Using the slider tool, moving the slab down through the B-scan image, we can firstly see on the transverse section OCT image multiple cysts and hyperreflective structures consistent with exudation. A small ring-like vascular lesion is observed with retinal vessels that seem to converge on that point. As we move the segmentation slab deeper, we can see that there is a vertical pattern of flow which extends from the RPE down to the RPE elevation, and the flow continues below. Some caution needs to be applied here in interpreting this change, as the RPE acts as a highly reflective structure, and even with projection artifact suppression, there may be some projection artifact visible here. But we can quite clearly see by moving the slab up and down the retinal anastomosis. This case shows again a patient who's not responded to VEGF antagonist therapy. The early ICG angiogram shows some early hypercyanescent lesions with what appears to be a supporting vascular network. The mid-phase ICG angiogram starts to demonstrate the classic grape-like cyanescent pattern of PCV, which again is confirmed in the late phase ICG image. The fluorescein angiogram again shows a highly exudative and leaky pattern corresponding to the PCV change. The OCT shows again steep peaked elevation of the retinal pigment epithelium with a hyperreflective circular structure within the pigment epithelial detachment. The display tab again shows elevation of the RPE on the OCT B scan with flow within the elevated RPE. This correlates to the vascular lesions that can be seen in the avascular complex. Using the OCT Angiography display tab, again using the retinal segmentation allows us to identify the subretinal vascular lesions, which appear on both the full and the retinal segmentation. We could also see a more extensive vascular network using the full segmentation position. Superficial and deep segmentation are not particularly revealing, but the avascular complex shows some large abnormal vessels. Choriocapillaris is slightly disorganized, as is the deeper choroidal structures. Using the slider tool now, and moving the segmentation slab down from a superficial position to a deep location, on the transverse section OCT we start to see a series of circular or oval lesions appearing, and this correlates to the first vascular lesion. We see a tented appearance to the RPE with a hyperreflective circular lesion beneath, in which we can isolate flow. Again, moving the segmentation slab deeper, we now see the classic ring-type pattern associated with RPE elevations on the transverse section OCT. And once again, on the on-vas OCTA image, we're now seeing multiple vascular lesions, again associated with a steep elevation of the RPE with flow recorded beneath. Again, moving the slab deeper, again identifies further lesions. Moving the segmentation slab deeper to a position beneath the RPE, a larger vascular network is then identified. Localizing this position allows us to see a larger branching vascular network associated with the choroidal polyps. Again, using the slider tool to isolate structure and flow confirms the location of the flow beneath the retinal pigment epithelium.
These are very nice images of PCV using OCTA. It can be quite difficult to identify PCV using this modality. This raises the question of what to do if they are not identified, and of course these images have to be put into clinical context and suspicion, and maybe other imaging modalities need to be used. The ICG shows pooling of the dye, however the OCTA doesn't show this corresponding feature. This is because of the nature of OCTA. What we see here is the vascular component rather than the leakage.
This case is of a young female patient who is visually symptomatic. The near-infrared reflectance image shows regions of hypo and hyperreflectivity. The autofluorescence image shows areas of hypoautofluorescence. The early fluorescein shows areas of early leakage and possible window defects. These areas stain and leak early in the mid-phase of the angiogram, and the late-phase angiogram shows areas of increased fluorescence within the macula and vascular staining and a hot disc. The OCT scan shows areas of subretinal hyperreflective material, a shallow elevation of the RP, and intraretinal cysts. And the OCT thickness map shows areas of retinal elevation and thickening. The OCT angiography, again, zooming in on the B-scan image, allows us to visualize subretinal hyperreflective material with isolated flow. This is correlated with the B-scan position, moving it across the transverse section OCTA images. Using the retinal and full segmentation positions shows two subretinal vascular lesions with more information visualized on the full retinal segmentation. Superficial vascular complex looks relatively normal, as does the deep vascular complex. The avascular zone shows two discretely identified vascular lesions with disorganization of the choriocapillaris and also the choroid. Again, using the slider tool allows us to visualize a relatively normal superficial retinal with intraretinal cysts. There are two very clearly described vascular lesions anterior to the RPE. This again is confirmed by using the colocalization technique, clicking on the vascular lesions and correlating the changes observed within the B-scan images. Using the choriocapillaris segmentation position and creating a 40 micron thick slab allows us again to investigate deeper by using the slider tool and identify deeper choroidal changes.
This is a case of multifocal choroiditis that has some of the characteristic imaging qualities. The multiple discrete type 2 lesions would be consistent with this. Of course, it's important to put these imaging characteristics in context with the clinical picture, the patient's age, the inflammation within the vitreous, and also to look at the periphery to see if there are any characteristic signs as well. One important or interesting area to note is in the bottom left corner of the choriocapillaris slab of the OCTA, where there is a area of apparent reduced flow. It would be interesting to postulate what this may represent, either masking due to lymphocytic aggregate or due to capillary dropout.
This case is of a patient who is highly myopic and is visually symptomatic and has been identified as having myopic degeneration. The infrared reflectance image shows extensive RPE disruption, and the OCT B-scan shows an area of subretinal hyperreflective material consistent with a myopic CNV. The OCT thickness map again shows areas of retinal thickening and elevation. The OCT angiography again shows a clearly defined vascular lesion in the avascular complex. Moving the B-scan across this region allows us to identify flow within the area of subretinal hyperreflective material. Taking our systematic approach to evaluating OCT images, looking at the retinal segmentation again shows an area of subretinal choroidal vascularization, which again is demonstrated on the full and the retinal segmentation. The superficial vascular complex is comparatively normal, as is the deep vascular complex. The vascular complex shows our clearly defined vascular lesion with this organization and low flow signal in the choroid and choriocapillaris. Again, using the slider tool allows us to appreciate the three-dimensional nature of this vascular lesion. The B-scan image has been oriented in an oblique angle to allow for irregular rear ocular surface and astigmatic error within the patient. Again, using the choroidal segmentation and increasing the slab thickness allows us to assess the choroidal changes more effectively and reveal possibly an additional cult component. Here is an example of a normal subject with high astigmatism using a conventional OCT scan. Note the poor quality of the OCTA images. By scanning this patient with high myopia and an astigmatism through their spectacles, we're able to improve the image quality quite dramatically. Note the increased resolution of the OCTA images. Unfortunately, a bright reflex is noted on the reflectance images caused by the patient's spectacles. This, however, improves the image quality quite dramatically for the OCT angiography.
Myopic CNV are often small and mushroom-like and often don't display the characteristics of activity that we see in age-related forms, such as subretinal fluid or intraretinal fluid. This opens up the debate of how we determine activity, or if we can determine activity using OCT angiography. There has been discussion around the size and maturity of vessels, but I think this is still yet to be proven in prospective clinical trials.
In some cases, utilizing the B-scan information with the flow overlay may be more valuable than looking at the transverse section OCTA image. In this particular case, we have an elderly patient who's been undergoing anti-VEGF therapy, who now has an area of retinal pigment epithelial detachment, subretinal fluid, intraretinal fluid, and subretinal fibrosis. The B-scan image confirms this appearance. The classic sort of onion sign, the layered down subretinal fibrous material, the elevation of the RP, subretinal fluid and intraretinal fluid. Again, the OCT thickness map shows areas of gross retinal elevation and thickening. Evaluating the OCTA image now can be achieved through two techniques, either using the 3-up display image, first zooming in on the B-scan image and then scrolling through the vascular lesion using the slider and visualizing the flow information and where that is located on the B-scan image. In this particular case, we can see that the vast majority of the flow is in a subretinal location. The alternative is to use the B-scan image and simply use the replay facility, which allows you to steadily scroll through the B-scan information, again correlating the position of the flow versus the structural information. The exported image from this case shows again the fundus reflectance image, the OC B-scan information, the B-scan on flow, and the isolated flow information. The second example shows a patient with a fibrovascular PED. Again, this time the flow information can be identified beneath the retinal pigment epithelium. And finally, a serous pigment epithelial detachment, which shows a hyporeflective region underneath the RPE, which is devoid of any flow signal. Our final case is of a patient undergoing treatment for neovascular AMD with anti-VEGF therapy. The color image shows classic appearance of a mature CNV with subretinal fluid. The infrared reflectance image again shows RPE disruption, evidence of cystic change, and again changes that are consistent with subretinal fluid. The OCT shows signs of intraretinal cysts, and the fluorescein angiogram shows early leakage, which initially is lacy in appearance and starts to leak rapidly, staining late. All of these indicate signs of activity within a lesion. Whilst the OCTA image very clearly demonstrates the vascular lesion, it does not necessarily show signs of activity. A fine capillary fringe within a CNV lesion has been described as a sign of activity, but this is actually quite difficult to determine just simply based on visualizing the transverse section OCTA in the avascular complex. Using our systematic approach, we can see we have a subretinal vascular lesion visualized on the full and retinal predefined segmentation. The superficial vascular complex is relatively normal, although cystic change is observed on the transverse section OCT. The deep vascular complex shows segmentation error, and the avascular complex a fine lacy vascular lesion. There is some masking of the choroid and disruption and disorganization of the choroidal vasculature. Using the slider tool, again, allows us to identify an area of type 2 choroidal neovascularization. And a fine lacy capillary fringe can be identified at the edge of the lesion. This in itself is not a particularly good indication of activity. However, looking at the transverse section OCT, areas of hyporeflectivity can be identified, which correlate to regions of subretinal fluid, again, which are clear signs of activity.
An interesting point has been made about how to determine activity on OCT angiography. Some would argue that a lacy fine vessel fringe to an OCTA-derived neovascular membrane would denote signs of activity. This is yet to be shown to be a very reproducible or reliable sign. As a word of caution, it's sensible not to rely upon these signs as of yet as absolute predictors of activity of a disease process. We've heard some great case examples where OCT angiography has been used in the environment of neovascular AMD. Most of those cases have been around age-related macular degeneration, but there are also some non-age-related macular degeneration cases as well. Although it's very important to embrace this new technology, I feel it's important to understand that it's quite embryonic in some aspects, and really we need to define where the place of this amongst the other imaging technologies. So we've heard about many advantages of being able to identify flow and characteristics to support diagnosis, but also a few words of caution about some of the limitations and drawbacks as well. Of course, it would be sensible not to wholly rely upon neovascular AMD being diagnosed with OCTA at the moment, unless we were absolutely sure that it fitted with the clinical characteristics. The fallback picture is always to look back at conventional dye-based angiography or other imaging modalities as necessary.